Welcome to USMLE educators. Our first video will be on hemostasis. We'll cover the entire chapter of hemostasis. This is a quick revision and oriented towards step 1 for USMLE. So hemostasis occurs in two steps, primary and secondary. Primary is sort of a temporary platelet plug that occurs in response to a vessel or endothelial injury. So after an injury, there will be vasoconstriction and exposure of subendothelial collagen, of course, and with this exposure of subendothelial collagen will begin our primary hemostasis pathway. So we start with von Willebrand factor binding to the subendothelial collagen, and this von Willebrand factor is very important as we need to know the source of this. It is released from platelet alpha granules and most importantly, weevil Polari bodies of endothelial cells. Now, the subendothelial collagen is exposed. Von Willebrand factor binds to the subendothelial collagen. Now, the platelets have a receptor that identifies von Willebrand factor, which is bound, and then it binds to von Willebrand factor. So the platelet binds to von Willebrand factor via GP1B9 receptor, and there are pathologies related to that. So this will be an important aspect. And mind you, this will be platelet adhesion. Platelet aggregation and adhesion are two separate things. This one, platelet binding to von Willebrand factor, is called platelet adhesion. So after platelet adhesion, there is the next cascade, which is there is the next step, which is release of ADP and thromboxane A2 by platelets. It occurs internally via the COX pathway, and these two molecules cause stimulation and expression of GP2B3A receptor, which is another molecule or another receptor of clinical importance as there are pathologies associated with it. Now the platelets which are bound to von Willebrand factor start interlinking with one another via this GP2B3A receptor and with other platelets that are in the circulation, and the linker molecule will be fibrinogen. So this pathway stops here at fibrinogen level. So it's in the coagulation cascade, which will be the secondary hemostasis, we'll talk about fibrinogen being converted to a more stable fibrin platelet plug that is rigid and stable. But this is a primary pathway which forms a temporary and weak platelet plug. So the two take-home messages are the GP1B9 receptor, which is responsible for platelet adhesion, and GP2B3A receptor, which is responsible for platelet aggregation as more and more platelets come together and bind via the fibrinogen linker molecule. So let's see into a diagrammatic representation. So we have let's have this blood vessel. We have an endothelial damage over here, and as the subendothelial collagen is now exposed, von Willebrand factor is released by the adjacent cells, and it binds to the subendothelial collagen. Now the thing you see in the red is platelet adhesion, and it is via the platelet GP1B9 receptor. After this, as we discussed, ADP and TXA2 are released, expression of GP2B3A receptor, and there is platelet interlinking, and this is called platelet aggregation. So we've learned about primary hemostasis. Now let's look at the pathologies of primary hemostasis. So the disorders of primary pathway. Let's see the symptoms and signs first. So in symptoms and signs, we'll see skin and mucosal bleeding. This bleeding will be particularly superficial. So skin bleeding will be seen as presence of petechia, purpura and ecchymosis, and these are in the increasing order of their size. Petechia smallest, purpura mid, and ecchymosis the largest. Apart from that, we'll see mucosal bleeding, and in mucosal bleeding, you can remember it as just recall every system and so, what happens if there is bleeding in the mucosa and what symptom is there. So, as in the respiratory system, you'll have hemostasis. In GI, you'll have GI bleeding. Uh, in renal system, there will be hematuria. In reproductive system, there will be menorrhagia. CNS, we'll see CNS bleeding, intracranial bleeding, and most common one is the epistaxis or the nose bleeding. In labs, we'll see platelet count will be decreased, thrombocytopenia, then there will be increased bleeding time and normal platelet prothrombin time and PTT. Also, we'll see megakaryocytosis on bone marrow biopsy. It makes sense because as platelets are depleted, the bone marrow is trying to make up for it and making more and more platelets. So let's see the disorders of primary hemostasis. So we have a quantitative and qualitative defects. Quantitative means there is decrease in quantity of platelets, and qualitative means there is destruction of the quality. There is degradation of the platelets, and so they are not of optimal quality. In quantitative, we have the first one is immune thrombocytopenic purpura (ITP), the most common, and characterized by autoantibody against GP2B3 receptor. So we'll just stop here and we'll go backwards and see what was GP2B3A doing. So we see here the GP2B3A along with the linker molecule was responsible for platelet aggregation. So therefore we should see platelet aggregation defect in this thing. So I will keep that in mind and move forward. These autoantibodies are generated in the spleen and platelets are attacked, and they're also the attacked platelets are also consumed by the spleen. So antibodies are generated in the spleen, they attack the platelets, and the platelets which are destroyed by the antibodies are grabbed and consumed by the spleen. They are IgG class antibodies, and treatment will be corticosteroids. Next set of disorders is comes under the broad heading of microangiopathic hemolytic anemia. Mind you, these are not the only causes of microangiopathic hemolytic anemia, but these are two of the causes of MAHA. So the first disease is TTP, thrombotic thrombocytopenic purpura, and the second is hemolytic uremic syndrome (HUS). So in TTP, we have decreased ADAMTS13. What is ADAMTS13? ADAMTS13 is a molecule which prevents the formation of multimers or polymers of von Willebrand factor. So the von Willebrand factor will not be like joining together and forming larger units of it. And ADAMTS13 will cleave those polymers or multimers, and therefore von Willebrand factor remains functional. If this is deficient, von Willebrand factor no longer remains functional, which causes increased platelet adhesion. So let's take a step back here and see the role of von Willebrand factor, which is right at the beginning where subendothelial collagen is exposed, and von Willebrand factor binds to that, which causes platelet adhesion. So here in TTP we'll have a defect in platelet adhesion. There will be increase in platelet adhesion because von Willebrand factor is more and more present at the site, which will cause platelet consumption, and therefore there will be decreased platelet count. But of the two disorders being talked here, this one primarily results in CNS bleeding. So in hemolytic uremic syndrome, it is caused most commonly by a specific strain of E. coli, which is O157H7 infection. E. coli secretes a virotoxin, which is an endotoxin, and it destroys the endothelial cells. and there will be predominantly renal symptoms, please excuse me, in hemolytic uremic syndrome. So these two comprise of microangiopathic hemolytic anemia, and as will be forming little thrombi, there will be little small platelet plugs formed throughout the circulation. So when RBCs pass through a narrow vessel with thrombus, they are sheared off, and they present as small helmet cells. So the RBC will be of this shape. So it also called as helmet cell or schistocytes. Alright, let's continue. So now we've completed the quantitative defects, which were the ITP, TTP and HUS. Now let's go to the qualitative defects. So in qualitative defects, we have a defect in the quality of the platelet. The platelet is not of proper quality so that it can normally function. So one of the disorders is Bernard-Soulier syndrome. Here we will have an antibody formation against GP1B9 receptor. Now we remember that GP1B9 was responsible for platelet adhesion. So platelet adhesion is impaired, not aggregation, adhesion. And as there's a little mnemonic here, so big B, the initials of the disorder, BS, big, this will be larger sized. Second, in the qualitative, we have the Glanzmann thrombasthenia, where there will be antibody against the other receptor, which was GP2B3A. And as we saw in the mechanism, platelet aggregation will be impaired here, not adhesion but aggregation. So these are these are the antibodies secreted against specific receptors of platelets, and there are some applied aspects as well. For instance, in case of aspirin, we give small doses of aspirin which blocks the COX blocks the COX pathway. Sorry, and therefore TXA2 from thromboxane A2 cannot be synthesized by platelets, and it was also one of the steps that was required for expression of GP2B3 receptor. Let's take a step back and let's see that. So after binding of GP1B9 to von Willebrand factor, there is release of ADP and thromboxane A2 by platelets itself via the COX pathway, and that causes expression of GP2B3 receptor. So we have reached till here, and we are not able to reach these steps. So there will be impaired platelet aggregation. Adhesion will be there, but aggregation won't be there. Alright, let's come back. So we were talking about aspirin, and it inhibits platelet aggregation. So it is used as a blood thinner agent. You must have come across this in cardiology OPDs or cardiology clinics, where aspirin is a very common prescription at low doses in coronary artery disease patients, and this is sort of the mechanism why aspirin is being used. Second is uremia. Uremia causes disruption of platelet function. Both adhesion and aggregation both are impaired. The mechanism is beyond the scope of this video and for the step 1 exam, but you just have to remember that uremia due to any cause, any renal dysfunction which causes increased urea levels, will cause platelet dysfunction, both adhesion and aggregation. So with this we've covered the disorders of the primary pathway, primary hemostasis. Now we shall move on to the secondary hemostasis, which with the function of which is to stabilize the platelet plug using coagulation factors which are synthesized by the liver. So let's go to the coagulation cascade. Now we know the coagulation cascade has intrinsic and extrinsic pathways. The intrinsic pathways is begins with the exposure of subendothelial collagen. There will be formation of primary platelet plug, and then after that the factors come into play. So it begins with factor 12, goes so in order to remember this, there is sort of mnemonic. First you go downwards from 12, then 12, 11, skip 10, then 9, 8, and ultimately reach 10. I think this is incorrectly mentioned here. Let me just erase that. This is not fully thrown. So factor 10. On the extrinsic pathway, you start with tissue injury, or which activates tissue thromboplastin, and this will be linked with the amniotic fluid embolism when we study embolism in the end of this chapter. So it stimulates factor 7, which activates factor 10, and therefore after a series of reactions, fibrinogen is converted to fibrin. That is a major role of the secondary pathway, to convert fibrinogen to fibrin in order to stabilize the platelet plug. And there is a little mnemonic here. So in the extrinsic pathway, you see there are only two factors involved. So the measurement index that we have also contains two letters, P, T, and on the intrinsic pathway we have more factors involved, and therefore we have more letters in the name, PTT. And heparin works on the intrinsic pathway, inhibiting these factors and the common factors, and warfarin inhibits the extrinsic pathway and the common pathway. So now that we're aware of the normal pathway of secondary hemostasis, we can discuss the disorders of secondary hemostasis or the coagulation cascade. And first, let's discuss the signs and symptoms. So remember, with primary hemostatic pathway disorders, we just had superficial bleeding, skin and mucosal bleeding. Mucosa is superficial. I say superficial because mucosa is towards the lumen side. Therefore, I call it superficial. But in secondary hemostasis, there is deep tissue bleeding. For instance, bleeding into a muscle or bleeding into a joint, which you might have heard as arthrosis. So there will be normal platelet count, normal bleeding time, but the clotting time will be increased, and there will be deranged prothrombin time or PTD depending upon the pathway. The first disorder is hemophilia A, which is a very common disorder, and a very important thing that you must remember, you must take home, is that it is X-linked recessive. This will somehow be asked on the exam, maybe as a direct vignette or an indirect thing, but you gotta know that. X-linked recessive. It is a genetic deficiency of factor 8, and this factor 8 will be linked to von Willebrand disease, which we will discuss later, as von Willebrand factor stabilizes factor 8. So von Willebrand's disease is a mix of primary hemostatic disorder and secondary hemostatic disorder, but we are primarily discussing it under secondary hemostatic disorders. So we'll have deep tissue bleeding and post-surgical bleeding. For instance, if someone goes for extraction of wisdom tooth, there will be post-surgical bleeding in case of hemophilia A. And as we have factor 8 involvement here, which is an intrinsic pathway factor, will have increased PTT levels and normal PT levels. Treatment shall be recombinant factor 8. This will have to be given lifelong. Another disorder is hemophilia B, which is also called Christmas disease, as there is genetic deficiency of factor 9 instead of factor 8, and factor 9 is also called Christmas factor. That is why it is called Christmas disease, and all the other signs and symptoms will be same as that of hemophilia A. Now comes an important disease, which is coagulation factor deficiency. So coagulation factor deficiency is an acquired antibody against factor 8. So most of the you can, if you have difficulty in remembering all the uh, deficiencies, you can remember most of them converge onto factor 8. Hemophilia A starts with factor 8, hemophilia B is close to 8, 9, coagulation factor deficiency again factor 8. Then we'll study von Willebrand's disease, also factor 8 involvement is there. So most of them revolve around factor 8. And a mission critical point that you need to know here is we perform a mixing study to differentiate this from hemophilia. And what we do is we take the patient's plasma. In the left side you can see we have patient's plasma, but there are no antibodies present against factor 8 in first diagram. In the second diagram, the patient has coagulation factor deficiency and the plasma contains antibodies. So when you add normal plasma to both, what do you expect? In the hemophilia patient, the defect will correct because there was deficiency of factor 8 and you just added new factor 8. So the deficit corrects. But in coagulation factor deficiency patient, there won't be any improvement in the symptoms, or there won't be improvement in the deficit, as these antibodies which are present will destroy the incoming new factor 8. So that is the mixing study. You have to remember that, you have to know that. Extremely important. Now, the most common inherited coagulation disorder, von Willebrand's disease. This is autosomal dominant. Now, the general schema of genetic disorders is that if there is an enzyme deficiency, it's generally autosomal recessive. Otherwise, we specially mention it, and I'll keep on mentioning if it is other than autosomal recessive. For instance, we mentioned an X-linked recessive disorder previously, and now in von Willebrand's disease we are mentioning separately that it is an autosomal dominant disorder, and a few other disorders will be coming up further in the text, and we'll discuss them there. So first thing, autosomal dominant von Willebrand's disease. Second, it is the most common inherited coagulation disorder, and there is impaired platelet adhesion and increased PTT. Now, why these two things? So we need to go back to our mechanism here. So von Willebrand factor was binding to subendothelial collagen, and platelets GP1b9 receptor was binding to von Willebrand factor. Now the von Willebrand factor is defective, so platelet cannot bind to it. So there will be impaired platelet adhesion, right? And then there is one more function of von Willebrand factor, which is to stabilize factor 8. That's right, again factor 8. As we discussed earlier, there is factor 8 involvement here as well. So von Willebrand factor normally stabilizes factor 8. If von Willebrand factor is deficient, factor 8 won't be stable. Therefore, we'll have some hemophilia A-like features as well. And what is important here is abnormal histiocytin test. So histiocytin, what it does is it agglutinates platelets. So if you add histiocytin, the platelets start to agglutinate and start binding to von Willebrand factor. Now we don't have von Willebrand factor, so there will be no platelet adhesion, and this will be called an abnormal histiocytin response, which is seen in von Willebrand's disease. So that is the abnormal histiocytin test. There will be no platelet adhesion, and platelet agglutination will not take place. Right. So the treatment of von Willebrand factor deficiency will be desmopressin. Desmopressin is an ADH analog which causes release of von Willebrand factor from Weibel-Palade bodies. And sort of thing which I missed earlier is you can remember Weibel-Palade bodies from the name von Willebrand factor itself. So We generally write small v, capital W, capital F. So this middle capital W is for the Weibel Palade bodies. It's not actually for Weibel Palade bodies, but it's just a mnemonic, and we can sort of remember this from this thing. The other thing the Weibel Palade bodies secrete is p-selectin, which is involved in inflammation and the white blood cell slowing down pathway. So now we have vitamin K deficiency, the fourth disorder of secondary hemostasis. So normally vitamin K is activated in the liver by vitamin K epoxide reductase enzyme, and this deficiency will be seen in newborns particularly, as the breast milk is deficient in vitamin K. That is why you see if you attend pediatrics clinics, you'll see if a newborn child is always given vitamin K injections right at birth, because the deficiency can be critical and it can cause bleeding disorders in the newborn. So it's plausible to give a vitamin K injection at birth itself. And in long-term antibiotic therapy, so this ties with the gut bacteria. Gut bacteria normally produce vitamin K, but like if there is if there is a long-term antibiotic treatment that has been given to a patient for any reason, that will deplete the gut bacteria and decrease vitamin K levels. And finally, malabsorption syndromes, which will decrease the absorption of fat soluble vitamins like vitamin A, D, E, and K. So this activated vitamin K is required for activation of factors 2, 7, 9, 10 and protein C and S. The factors 2, 7, 9, 10 are procoagulant, which means they will increase the coagulation, and protein C and S are anticoagulants, so they'll shut down coagulation. But important thing is vitamin K is required for activation of factors 2, 7, 9, 10, but with vitamin K, this has to be activated by vitamin K epoxide reductase. And if there is a liver disease where the epoxide reductase is not functioning or vitamin K is deficient, both will have the same disorder. So the other causes of secondary hemostasis disorders can be liver failure. So the factors, all the coagulation factors are not synthesized, and we use prothrombin time as a surrogate marker to measure the amount of liver failure which has occurred over the time. And of course, a large volume transfusion, because if you're transfusing a large volume of packed RBCs, then you're filling up the entire circulation with RBCs, and the per milliliter quantity of platelets reduces. The absolute does not vary specifically, but it could be if the patient had presentation of shock, so there was bleeding, so he lost all the components of blood. There was absolute reduction in platelet count, and now we're just infusing packed RBCs. So we replenish the RBCs, but not the platelets. So the platelets that were decreased during loss of blood, that will manifest here, plus the plasma coagulation factors as well. That is why under secondary hemostasis. That concludes the disorders of primary and secondary hemostasis, but we have more things to discuss. There are a few miscellaneous disorders of hemostasis. The first one is heparin-induced thrombocytopenia. This is this is a disorder which is caused by heparin. So normally we use heparin and then switch over to warfarin if a patient has to be on anticoagulant therapy. When you start with heparin, in some patients there could be a binding with heparin normally binds to platelet factor 4 and forms a complex with platelet factor 4, and hence this platelet factor 4 heparin complex is identified as foreign by the body, and antibodies are produced against it. The antibodies subsequently will destroy the platelet factor 4 heparin complex, and it will induce other platelet activation and destruction as well. So there is a picture of thrombocytopenia. So upon giving heparin to a patient, there could be decrease in platelet levels because they are being increased destruction. There is increased destruction of platelets due to antibodies because of the platelet factor 4 binding capabilities of heparin. The treatment would be to stop heparin and not give warfarin, because there would be increased chances of warfarin-induced skin necrosis. So this you have to keep in mind. You have to rely on other anticoagulants. The anticoagulants apart from heparin and warfarin. Heparin is the main culprit, but warfarin in this case could cause severe warfarin-induced skin necrosis. So refrain from giving warfarin. The next one is a very important one, and is a real issue if it occurs in clinics. It is disseminated intravascular coagulation. So here we have pathological activation of coagulation cascade. Remember, the first word is pathological. It's not normal, it's not physiological, it's not due to a damaged vessel, it is pathological. The vessel is absolutely normal. There are some things that are occurring pathologically which will activate the coagulation cascade, and there will be widespread microthrombi throughout circulation, which will consume platelets and factors, causing deficiency of both platelets as well as factors, and there will be increased risk of bleeding. So this is a sort of contradictory situation where there is increased thrombus formation, there are widespread thrombi throughout the circulation, and still we have bleeding tendencies, high risk of bleeding. And as a symptom, you can see in clinics generally we have IVs installed. We have IVs in a patient. So there could be bleeding from the intravascular sites or bleeding from the natural body orifices. So this sort of you need to understand the contradictory situation, that there is thrombosis going on as well as there is bleeding going on in disseminated intravascular coagulation. That is why the word disseminated. It's widespread, it's intravascular, there's coagulation and risk of bleeding as well. So the causes are the first and the foremost, the most important is the obstetric complications. Second, we have sepsis, particularly in Neisseria meningitidis and E. coli. Third, we could have adenocarcinoma, where mucin will induce thrombosis and coagulation cascade. Fourth is acute promyelocytic leukemia, where the dense granules containing our rods are responsible for the activation of coagulation cascade. Finally, we have rattlesnake bite, which the venom of which has hemolysis and also factors that activate the coagulation pathway. In laboratory, you'll see decreased platelet count because platelets are being consumed, increased bleeding time because of decreased platelet count, increased PT or PTT because of increased consumption of coagulation factors and widespread microthrombi, and there will be presentation of microangiopathic hemolytic anemia. Now let's take a step back and remember where we studied microangiopathic hemolytic anemia in the same text before. So it was in primary disorders, TTP and HUS. So here we had microangiopathic hemolytic anemia, which was due to microthrombi in the circulation, and these microthrombi, when RBC passes through the vessel containing microthrombi, it gets sheared off and produces schistocytes or helminth cells, which are ultimately destroyed and captured by the spleen. And the most important thing is in these patients is elevated fibrin split products, which are D-dimers. And please remember, D-dimer is very specific for fibrin split products. Fibrinogen split products will not be considered as D-dimers, and they can we'll see in the text further on the subsequent lecture that there are increased fibrinogen split products, but that is not D-dimer. In DIC, we specifically have increased fibrin split products because we know coagulation is happening, thrombosis is happening, but simultaneously the body also starts lysing the clot. So fibrinolysis is also going on at the same time. That is the reason why we have D-dimer elevation. The treatment is to treat the underlying cause, and we can give supportive treatment if there is a high bleeding and extremely low platelet count. We can give cryoprecipitate. So the last important thing in this text is fibrinolysis. So fibrinolysis is important as when there is a vessel injury, we had primary thrombus, secondary thrombosis. Sorry, we had primary hemostasis, then secondary hemostasis. So we formed a platelet dense plug after secondary hemostasis, and the vessel wall repair begins. Now that is the time when the vessel has already been repaired, and that clot is no longer required. So the body has mechanisms to destroy or lyse the clot that was formed, and now the endothelial cells also secrete a tissue plasminogen activator, which is very important in fibrinolysis pathway, as it activates a protein plasminogen to its active form plasmin. Now this plasmin will destroy fibrin and fibrinogen. It destroys coagulation factors and blocks platelet aggregation. Therefore, if the fibrin platelet plug already exists, it will break off the fibrin and it will dissociate the platelet aggregated thing, and the clot will now melt away, sort of melt away, and not actually melt because it's just an analogy. The plasmin, one more thing important to remember is alpha-2 antiplasmin, as the name suggests, will inhibit the plasmin, the active form that is ultimately doing the lysis. So we have a few disorders of fibrinolysis, and these are due to plasmin overactivity. Plasmin becomes overactive and increased lysis occurs, and there are elevated breakdown products of coagulation factors and excess cleavage of fibrinogen. And here, as you can correlate with the previous text, there is no elevation of D-dimers because it is excess cleavage of fibrinogen, not fibrin. Because this is a disorder of fibrinolysis, so this is the lysis pathway overacting or disorderly acting without the need of it. So when would normally physiologically you would need a fibrinolysis? You need it after fibrin platelet plug has been formed, but here there is a disorder of fibrinolysis. So fibrinolysis is not acting after that thing, after fibrin platelet plug, but autonomously or disorderly acting. So there is no platelet thrombus, there is no platelet fibrin plug, but still fibrinolysis is acting. So now it will start cleaving the coagulation factors and fibrinogen. This can be seen in liver cirrhosis. Why? Because liver produces all the proteins and it produces plasminogen as well, plasmin as well, coagulation factors is also. So there will be decreased levels of all these things. Then we can have urokinase released after radical prostatectomy, which also activates plasmin. So increased plasmin activation will be there, and increased lysis will be there. The presentation will resemble that of DIC except for D-dimer. So we have it in red here, no elevation of D-dimers. So rest apart from that, everything remains the same because we consume coagulation factors with the breakdown. So we'll have increased PT and PTT. We'll have increased bleeding time with normal platelet count. So why this is happening? The platelets are normal, absolutely normal. There is no damage to the platelets, but the platelet aggregation has been impaired, right? So if because the linker molecule in platelet aggregation was fibrinogen. Let's go back and see where this was, so that we can remember it. So here in GP2B3A interlinking of platelets, we had fibrinogen as linker molecule. The Here you can see it. The fibrin acts as a linker molecule between the green platelets, which are depicted here. So if there is no linker molecule, there will be no platelet aggregation. That is, that platelet aggregation is impaired, and which causes the increased bleeding time with normal platelet count, and of course increased fibrinogen split products and no elevation of D dimers. Treatment is delta aminocaproic acid, which inhibits activation of plasminogen to plasmin. So it does not let formation of plasmin. It inhibits the activation of plasminogen. Therefore, we can control it. So that was the disorders So this was hemostasis and its disorders. Now we do have two more topics left: thrombosis and embolism, which we'll discuss in the next lecture. If you found the video useful, please like, share, and subscribe. I will have a separate lecture for thrombosis and embolism, because there are some wide things we need to cover over here. But please be sure to like, share, subscribe, and visit regularly, and we'll have more lectures coming, high yield lectures coming. So thank you very much. Thank you for watching. If you want the notes PDF, we can share it with a drive link or something. Do let me know in the comments below if you need the PDF version, or if you need the notes. So they'll be provided in the description of this video if you need it. So tell me by commenting in the comment section down below. Thank you. This is USMLE Educators. Until next time.